AFMC, there is mediocrity in the teaching faculty as it stands. I'm sorry to say that, but being candid. So I thought Marrow steps in and covers that gap. Although it takes them away from bedside medicine, it takes them away, but then they have it at their palm tops. Any lecture, any demonstration of UMN science, element science, the works. And I'm told it costs about 40 grand for a year's subscription. So that's AI for you, which is already penetrated into the system. So let's see how things evolve.
Performances, Marrow is just shows a student scoring 300 out of 720, to get a score of 650. Everyone is looking at 600, but at that, to get 600, some commit suicide, some give up, some say become real estate agents. So what happens? You're the privileged people. You are the privileged people. Stay where you are and do your job, as General Nagpal said. Everyone has Marrow. The teachers are by the way. So if someone is teaching the mid-diastolic, they said he's useless because mid-diastolic murmur has gone out of the system.
But I'm glad we are not in that league. And would you take a brief interaction with the audience, Reggie?
Or... Not really, sir, because I'm scared to take their questions. But if you have any, you can try me because I don't promise. The disclaimer is I'm not a boss of AI. I think we'll leave it here, General Tareja.
Well, then let's applaud him in our usual manner.
Thank you, sir.
At the end of the session. So, ladies and gentlemen, that takes me to the next oration, personalized medicine in the era of AI, a very contemporary topic. Delivering this talk is none other than an academician par excellence, Lieutenant General Velu Nair, Param Vishis Seva Medal, AVSM, PSM and BAR. He is currently spearheading the hemato-oncology program as well as the BMT program at the Apollo Cancer Center in Ahmedabad. I leave it to the audience to go through this CV which is projected. It's very, very enviable, it's exceptional, and I dare say that it may not be emulated in a long time to come. So Velu, greater strength to you. Now, I first met up Velu, little bit of trivia, in the July of 1973 when we were roommates in 6 Mid 2. And as a batchmate from the earlier days, it was very, very obvious to us that this man stands head and shoulders above the rest. And he's cut out for much, much larger things in life. And he has proven that to be the case. Well, he's no stranger to this audience. We are all acquainted with his well-earned exploits, if I may call them, in the field of teaching, academics, research, and what have you. He has worn many hats, and there are many feathers in his headgear. His CV, as I told you, is very difficult to emulate. His dream run has been truly well-deserved. And as is customary, I'll briefly substantiate what I have spoken. Look at his, and it was no surprise that he headed the Army Medical Corps. He was dean of this prestigious institution as well as the ACMS. He is now currently the president-elect, or are you president already of NAMS, of National Academy of Medical Sciences? He's on the board or is the chairman of practically any national committee, work task force, or academic council. It's not a single one that he doesn't represent. And in doing so, he has raised the stature of the armed forces as well as this college. He has been instrumental in the framing of very, very robust guidelines at the national level for venous thromboembolism, for BMT, as well as nuclear emergencies. He had an insatiable appetite for publishing, and I think 300 odd publications bear that out, and we are still counting, Velu. So I don't think I could go on and on, but then I think we won't keep you away from the speakers. So it's all yours, General Nair.
A very good morning to everybody. I'm delighted to be here back in this auditorium. And every year I look forward to coming back here, actually. You get a high when you're here. And I must thank my roommate, my batchmate, and close friend, Akhil, for those kind words. And thank you very much, General Sandeep, for having invited me. And Major Sandeep is the first person I met him when he was a trainee. And dengue epidemic in 1996 was a monstrous epidemic. 4+ was the fatality rate. And the Army Hospital Commandant gave us a ward, and the two of us looked after that ward, and we got the first cell separator from the National Defense, management, disaster management funds. And he was also looking after the acute ward and the dengue ward, which was full. And I think he did an outstanding job. So I look forward to serving with him thereafter when Army Hospital twice, we were again working together as colleagues, and it's been a pleasure. Thank you very much. Raji, my very old friend, gave such a nice talk, and I could keep hearing, and I wanted him to go on. And as a matter of fact, like he said, the undergraduates is the people you really feel for, and you want to give it all that you can. I like to draw a distinction before I start my talk and my timings, okay? I start my timing when I start the talk. So this is the preamble. So there's a difference between tutoring and mentoring, okay? And so I just took a session for the National Academy on mentoring the mentee, okay? Tutoring is giving a lecture, going home, and he's scoring, going for exam and scoring. Mentoring is knowing that person. There's a continuum. It's not a cross-section. I know him today and know him for the next 2 years. And I know him, I know his nuances from his physical to his mental health and his capabilities. I put all that together and I have a holistic approach. That's mentoring a mentee. So with AI, just get out of the cross-sectional teaching of tutoring. Get into mentoring. And that I think is very, very important. And AI should not curb your creativity. Okay, so the last slide which Raji showed, I really liked, with him in the center and all the smart things around him. Don't let that happen. So don't let it kill your creativity. Now, I am going to talk on personalized medicine, which we've been practicing in hematology for nearly 12 to 13 years now. So it's what we do is what I'm going to show you. And my time starts now, Chairman, sir. Okay, can I... on the right is my Janama Bhumi. On your left is my Karma Bhumi. That's Army Hospital, okay? And in center is where I now work, Apollo Hospital, Ahmedabad. I head the Apollo Cancer Center. This is the outline of my talk. Now, artificial intelligence is known to all of you. We've already heard so many versions of it. And in your daily life, from GPS to Digi Yatra, we are seeing it, okay? So it's nothing unknown to us. But what we want to know is how it's transformed the future of healthcare. So I'm going to give you a little snapshot on AI with healthcare, then go on to personalized medicine, okay? Just see this slide. The light blue is the clinical trials in cell therapies for regenerative medicine and things like that. The dark one is gene therapies. You see from 2016 to 2023, we are actually galloping on, and gene therapies is catching up. And we're looking at about over a $50 billion market in another 4 to 5 years, which is a happening place, okay? And if you see this pie diagram, over 30%, both stem cells and gene therapies comes from oncology and hemato-oncology. So that was where the platform was launched from, okay? So it's becoming a big player in all fields. And one of the biggest fields is clinical trials. Cost money, difficult to do, and you never end up accruing the right amount of numbers that you need. So the biggest reason for termination of a trial today is not being able to accrue the patients, okay? And now AI can help you solve that to a large extent. You don't want a round peg in a square hole. So it matches the subjects to the right trials. And India is catching up, but in the West, it's a way of life, okay? So really speaking, that clinical trial is a very big thing. And you see the market size of the healthcare. You see in 23, just over 19 billion. The projected in 10 years is over 600 billion. A compounded annual growth rate of more than 36%, nearly 37%, which is fantastic, okay? And you see the literature, when you're doing it, you'll publish. So it's no longer theory. So see in the 98 and 2000s, a few hundreds. But today, it's in thousands, and every day, it's replete with articles, okay? Now, you see the share of the world with AI. North America takes nearly 50%. We in South Asia are 1/5, poised to cross 30 in the next few years, with China being actually added to this segment of the globe, okay? But still there are unmet needs. The WHO says 1 doctor per 1,000 population and 3 beds per 1,000 population. We are okay there, we're not badly off. But where we are badly off is coming to specialists in various parts of our healthcare system, from primary, secondary to tertiary. So district hospital level onwards, the specialists are just not there. They're conspicuous by their absence. This is the US model that you're seeing, okay? So here you see there is a supply-demand imbalance. This is what you need, and this is what you have. The last bit is what's now been taken out by the AI physician assistants and AI nurse assistants. The good part of these assistants is they don't come for casual leave. They don't come for sick leave. They don't complain of fatigue. So those are the plus points. But of course, I will tell you there are many negative points also. So it's not all plus points, okay? So do we have solutions to these shortfalls? The answer is yes. And the most important thing is, I think we are going to use AI to bridge the inequalities. And we should not, on the contrary, widen the gap between the developing and the developed, or the poor and the rich. And that's a very important catchword here. And that's happening, unfortunately. So we must make sure, like in COVID, the vaccines first went to North America and Europe. Then they suddenly realized, oh no, if it's in Africa, we're going to get it back. Some other strain is going to come back. So you can't just vaccinate in America and think I'm safe. You're not. So because diseases don't know barriers, they don't need visas. They just cross. And COVID taught us that, okay? Now, I was asked to give a talk for the UNESCO in 21, okay? It said AI for IA, okay? And this stood Artificial Intelligence for Information Accessibility. 140 countries attended it. It was a walk-in platform, all virtual, but it was beautifully done, just post-COVID. Okay, I really enjoyed talking on AI in healthcare, and we again talked with the hematology bias. Now, is it accepted by patients? To an extent. And what's really missing there is, the nuances of humane patient-doctor interaction. And the pandemic taught us that the human touch, wo nabs ko feel karna bahut zaruri hai. The good old adage, So with the PPE, when you went, you just were there like a robo. But he never got you to touch him, even when he died. So COVID-19 was a monster, which taught us that what empathy means, what physical contact means, and how much we crave to meet each other. So that's no different in medicine. So obviously, you can see there are big gaps which are not replaceable, okay? So acceptance by the healthcare workers, there's always a scare. Are we going to be replaced? But, don't forget the literacy amongst us is also, levels are not very high. The numbers are small, and actually the progress is not as fast as it should be. But the most important thing is what I told you. And we have to, tackle these things. And for that, as a country, we have to get active. What are the, regulated courses? What are the approved courses? When do I say you're AI qualified? And many things which are the ethics part of it. I'll talk about that. Okay. Now, the early adopters of AI-powered personalized medicine was things like IBM Watson, Google, Flatron, and Philips Health. These are all realities for different segments, okay? Apollo hospitals, where I work, adopted the IBM Watson model for oncology and genomics. Each cancer patient's cancer journey is unique, and there's a different treatment plan which is personalized. One size doesn't fit all. And to deliver this in unparalleled and personalized patient care across the hospitals is possible by using the platform of genomics and algorithm-driven, softwares which are now made available. Obviously, you have to pay money for it, but it's available to the Apollo group of hospitals. So coming to the key components of personalized medicine, starting from genomics to pharmacogenomics to biomarkers, and these are all we are using. These are all real time. There's nothing distant or artificial. And I rather call this as machine intelligence. There's nothing artificial about it. When a machine can take on a world champion on chess and beat him, it's intelligence. Nothing artificial about it. Only thing it was a machine. So I rather call it as machine intelligence rather than artificial intelligence. But by tradition, it hangs on. So we use these biomarkers, especially in cancer, for prognostication, diagnostics, and predictive value things. And these are actually happening. You see this picture here. This famous lady knows no introduction. Angelina Jolie actually got her BRCA test, BRCA1 and 2, which is a risk factor for cancer breast and cancer ovary, and runs in the families. And when she realized she's got it, she did prophylactic bilateral mastectomy, a huge thing for a Hollywood actress. Okay, then she realizes it can be ovarian also. She got ovaries and fallopian tubes to removed. So what is the message here? As a public figure, as a Hollywood actress, the public sat up and she was on the cover page of Time and said, this may be the way to go to prevent. There may be only 15-20% of the breast CAs which have a positivity rate here. But if you have it, God forbid, you are in for a big chance of getting the cancer. So if that's where we are in a good space. Okay. Now, we've been doing one size fits all. Anybody comes with any pain, any infection, we have a standard approach. Can we actually make it more personalized? And that's very important. And I will show you why. Okay, so on your left is one capsule which shows this is the treatment for everything. While here, multiple treatments for multiple problems. Advantages, adverse events can skyrocket here, minimal. Efficacy is much better here. And obviously, you get, much more benefits than actually problems when you can actually go on to personalized medicine, which is a reality. In a few years, they're going to demand it of you, okay? So personalized medicine, ladies and gentlemen, is a medical model that uses an individual's genetic makeup, genomics, and couple this with the lifestyle and the environment, and you tailor a algorithm to prevent, diagnose, and treat, okay? And that's also called precision medicine. And we use all these platforms. Now, this cartoon I made to show you, when I have cancer of the blood, it's called leukemia. Okay, you do a bone marrow transplant. The whole body suffers. You look like a Nazi victim. You lose your hair, you lose your skin, and 30 to 40% morbidity. So it's not a good space to be in, but it's hitherto incurable. So you're saving his life. But if I know where the cancer is, I can just knock off the cancer, it'll be very good. So this building has got a terrorist sitting in the middle room, okay? So what I'm going to do here is I'm using a missile to blast the whole house. I need not do that. Here is, I know where the terrorist is. Okay, I use a drone, I bring a targeted therapy, and I just knock him off. So can I just knock off cancer and spare the body? Yes, I can. By using the omics platforms. The omics platforms is, genomics is DNA, RNA is transcriptomics, and proteomics is proteins. These are all parts of the cell, go from the nucleus to the cell membrane, and they will all fit in, okay? And use all these data to integrate after analyzing them. And then you got the solution to apply in oncology. And today, the other subjects have come on board, okay? And this all started with nothing but the Human Genomic Project. 90 to 2003, 13 years it took. And what they did is they showed you what are the base pairs which make up the human DNA. And the genome was published in Nature. And the beauty about this was data sharing was open. Even before the publication occurred, data sharing was available to the world. So it became a biological platform for the world to use, which is fantastic. I think that's the way to go. Okay? And I am going to talk on some parts of this, which I've been doing for the last 15 years, cellular therapy and CAR T cell therapy. Okay? Now, about AI, every Uber, Ola driver will say, sir, mujhe excellent de dena, please. Mujhe, sir, 10 out of 10 marks de dena, please. And we all don't ask, though he was rude, he came late, charge you more money or whatever, you give him 10 out of 10. So when Ola or Uber analyzes their database, it's garbage. Okay, because if you put garbage in, you'll get garbage out. So the data which I feed for AI has to be unbiased, has to be big. And that is so, so important. So you have to honestly feed the data to get an honest algorithm out, which if you don't do, you'll get garbage. Okay? So you've got to be careful here. And so big data, medicine is the biggest example of big data. And we've got such a lot of big data. Stanford in the USA was the first one to tap on it. Okay? And they've used these 4 qualities: large volume, speed of data, velocity, variety, and veracity. IIT Delhi is working with AIMS on this. And I was an expert in that committee group. So got to learn a lot. How can you remove the background noise of big data to make sense of big data? And that is where we are today. Okay? And with that background, I'll take you to the regenerative medicine part, which is cellular therapy. First thing was bone marrow transplantation. Okay? This is an important graph. Looks busy, I'll make it simple for you. We are talking of 2 eras, 80 to 84 and 2000 2004. In the age group of 15 to 34 first, and can go to older ages. 10 years survival in acute myeloid leukemia, a monstrous disease. 80% mortality about 15, 20 years ago. Today, 70% survive. Now just see here, the red one in 80s, less than 20% survival at 10 years. With BMT and other tools, you have improved it to 50% by 2004. In 2024, it's somewhere here. So it's a revolution. And data has been used for this. Okay, data has been used hugely. And today, this is the jargon we use. This is the genomic talk. This is European Leukemia Net. This is practiced, gentlemen and ladies here. It is practiced. If you have adverse genomic data, you don't wait and play around with chemotherapy. We transplant him. If he is a favorable risk, again, this word I don't agree. In cancer, there's nothing favorable. Everything is unfavorable. But it just means it's milder. So if it's here, I can get away with chemotherapy and some targeted therapies. I may escape a transplant. So I know where to go for what. I don't go back to something because it's failed. So that's cutting short the journey of the treatment, which can be terrible. You see how much this background of data and AI has helped improve the outcomes. You see this, 1975 to 77 is the gray bar and 18 is the dark bars. You see in every disease, you see from 34 to nearly 70%. You see in myelodysplastic and myeloproliferative, these are both types of malignancies or pre-malignancies. It was, less than 5% living for 5 years. But today you see this, skyscrapers. It's like a T20 match. It's just taken off. And this is with targeted therapy, okay? Not by blasting. Now, this cancer, when I was training in hematology in the early 90s, this was the data. Adults, even 5 years, 30 to 40% survive, children 80%. Today, it's changed. It's changed what? The West, it's 95%. 95%. India, we are getting there. This is where we are. But we are getting there. And it's curable today. So eminently curable. And minimum chemotherapy is used. Now this cartoon, this is the tumor cell, this is the tumor cell, and this is the tumor cell. 3 molecules we are using to actually get to the tumor and spare the other parts of the body. This is called targeted therapy or monoclonal therapy. And this has been happening for some years now. 10 to 12, we've been practicing. Cost has come down. Now we'll have generics very soon. It's going to even come down further, which escapes, the major chemotherapy limbs are not followed. And we can mix and match all these therapies to give him a much smoother journey, especially for a child. So our transplant journey, we must publish in our Indian journals. And M. Jaffe, for example, should be propped up. I was responsible for getting it PubMed indexed. And thereafter, we actually made sure we published in it. And then only the impact factor comes up. So all of you, your good articles, publish in it. So this was a review we published, and this was our 700 patients from RR that we put together and published in M. Jaffe. So in regenerative medicine, we run trials. In the army, don't shy away from asking for funding from DBT, ICMR, all people give you funding. And I got the funding for my trials from these agencies because army did not have enough to give us that time. Now you are much better off. A predator cannot kill by attacking the tail of a lizard. It will shed that tail, but it will regrow it. Can we do this? Answer is no. Why can't we do it? These 4 genes, ladies and gentlemen, c-MYC, HEL4, OCT4, SOX2, have been silenced in us. The cost of evolution is the cost of evolution. So I cannot regenerate. If I put these back into a skin cell, a fibroblast or anything, I induced a somatic cell to become a stem cell. And the stem cell can regenerate. And that's called an induced pluripotent stem cell. And from my iPSC, I can make AB RH negative number of groups I want. I can get any germline, any mesodermal, ectodermal, or endodermal lines that I want. So organ systems can be made in the lab. And this is happening. We've already made models for the kidney and the other organs. It's already happening. It's not artificial. These are 2 gentlemen who got Nobel Prizes for this, okay? And this is Yamanaka in Tokyo and Gurdon in England, okay? And guess what? Our Prime Minister went to Yamanaka's lab, and in the Yamanaka's lab, as a matter of fact, he saw what's happening. He came back, it was in 2014, he had just taken over as Prime Minister. He told Mr. Jaitley that you have to give money. 200 crores was released within a few weeks. And there was a C-batcher from AFMC called Dr. Bhan, Secretary DBT, was the chairman of the steering committee. And it was given to NIMHANS, it was given to Vellore, it was given to INSTEM, NCBS Bangalore. And after 2 years, I took over as chairman of the steering committee. For the next 5 or 6 years, I remained there. And they made absolutely groundbreaking, inventions, discoveries, and it's on the world map. So I think this funding, the country like ours is just waiting to happen. And hematology has got about 4 Nobel Prizes in the last few decades for various work in this field. This is our 3 project that we did, the largest RCTs in the early 2000s. This was to regenerate stem cells in the heart. CTC, AFMC, RR was involved. I was the PI, AIMS, PGI, CMC, Vellore, they were all on board, okay? And no guesses for who this person is. He was a commandant in RR hospital, a cardiologist. Can anybody say? Yes, sir. So injecting stem cells into the coronaries, okay? And we found there was a 10-2 benefit, but our numbers were smaller. We need larger numbers to really make it significant. We had a p-value of 0.06. We needed another 50 patients. Same thing we did for stroke. It was published in Stroke. All Institute led this, and we all participated. We did this also for critical limb ischemia by injecting stem cells into the gastrocnemius, and we could salvage many limbs. Okay, so all these were examples of regenerative medicine using cellular therapy. Now I come to using cell engineering to modify a cell, and that's called CAR-T. CAR as not in Gaddi, CAR as in chimeric antigen receptor. Okay, now we are all making bad cells all the time, including cancer cells, but we all don't get cancer. Why? Because our immune system picks it up, clears it. There's a surveillance system. Okay? But the cancer cell, when it actually escapes that immune system, it's called immune escape. And that immune escape is dangerous. 2 cells become 4, 4 becomes 16, 16s are raised to the power of n. So cancer is dead. So immune escape is what you have to prevent. And if it happens, how can I restore it? Okay? Here are 3 cartoons. Just pay attention. A is the T cell is the surveillance cell, which actually picks up the cancer cell and kills it through the MHC molecule, is where the 2 bogies of a train get attached to each other. And that's a disaster for the cancer cell. The cancer cell dies. Okay? Now, the cancer cell sheds the MHC receptors. So there's no MHC here. So that's an immune escape. So the tumor cell says, oh, the cell is okay. He thinks it is self and not non-self. Cancer cell is not self. It's non-self. Okay? So here it escapes and then becomes cancer. What we do in CAR T cells is we engineer this cell in the lab and put fresh receptors to pick up these receptors, which any cell will have receptors. Can you recognize them is the issue. Can your immune system recognize is the issue. So we train and re-engineer this to have receptors to pick up this and then kill the cell. That is CAR T cell in a simple form. Okay? So it's nothing. CAR T cell is, if you see here, this is the tumor cell, this is the CAR T cell. So in the CAR T cell, I'm putting a receptor to pick up the tumor and kill it. So it's a living drug. It's a living drug, like an antibody. You see? But I'm creating this in the lab. Okay? Now, if you see this 3 here, this is immunoglobulin. If it's a mouse, pure purple, human, blue. If you mix and match, it's a humanized mouse model. But there are 2 genetic components here. And when you have more than one, there being 2 or more in the same human being or any animal, it's called a chimera. So chimera mythologically is this, you know, and this is what we do in science. So whenever you have 2 genetic sources, it becomes a chimera, and that's exactly what happens here in CAR T cells. So CAR T cells is a form of cellular immunotherapy. Okay, this looks busy. Let me make it very simple for you. How do we actually do it? So we've already done our first case. So in the clinic, we take off just like platelets. We take off on a cell separator. We take off the cells, and that's the leukophoresis. We take off the cells. The cells are brought to the lab. And the lab manufacturing, this is a T cell. Into this T cell, I put a virus with a construct. And this construct, the virus carries into the patient's T cell and takes over the DNA and starts making the receptors, which is what the construct is all about. And these receptors are on these cells, then we amplify the population into millions of cells. And then I take it back. If you see here, the receptors are attracted to the targets on the surface of cancer cells. Now I made the correct receptor and the immune escape of the cancer cell. I've called the bluff. I've caught him. So we log on and you see what happens. It pulverizes the cancer cells. Okay? And this is a live sign film to show you. The green cells are the T cells on your right, and the blue cells are the cancer cells. See what it does, okay? It's gone. So it's eaten it up like a phagocytosis. So that's exactly what happens. But there's always a flip side. So when we started CAR T cell therapy, we had a lot of cytokines. When the cells kill, chemicals are released. They're called cytokines. And those cytokines can cause neurotoxicity, can cause fever, can cause infection risks. All this was there in the first generation. Okay? But, you know, we are restless people. Clinicians especially are restless people. So that's why we must have a lab to vent all our restlessness. Okay? So this is the first generation where we got a lot of cytokine release and things like that. This is the cell membrane. This is the extracellular part. And this is the intracellular part. So the tail gets longer here. And why is the longer tail? These are co-stimulatory molecules to prevent the side effects. So I can prevent the cytokine release. I can prevent as many off-target effects as I want, which is great. I only want to kill the cancer cell. So be as pure as you can. And that's what the 5th generation is all about. We are here right now. Okay? This girl from Pennsylvania, Emily Whitehead, is a heroine today. When she was a young girl, chemotherapy failed, bone marrow transplantation failed, the parents wouldn't give up. They found there's a lab in Pennsylvania doing CAR T cell experiments. They went to him. He said, unless there's a trial, I can't take you on. They got FDA to sanction a trial. And this, ladies and gentlemen, was now nearly 12 years ago, I think. She's alive. This is of 22. And today, she's all over the place, 12 years down the line, cancer-free after CAR T cells, 1st generation. Okay? So we have perfected this to an extent for lymphoblastic leukemia and lymphomas. Okay? But for solid tumors, there are some problems. I'll tell you that. Now, these are the areas where research is going on. I had the fortune to be the chair and then the co-chair of the funding committee. We gave 25 to 30 crores to about 8 institutes, and some of them have produced it. 2 have already come out with the cells. The others are on the way. It's an action in hand, work in progress. Multiple myeloma, and these are the difficult ones, the solid tumors, okay? And I'll tell you why it's difficult. So if you just see the lower part of this and see only E, the microenvironment of a liver tumor or any other solid tumor is very hostile, very hostile. All these chemicals and cells prevent the T cell from entering that place. It knocks it off before entering. So the microenvironment is so toxic, I must find a Trojan horse to take it in. And that is where we are. Can I break this fortress of a solid tumor? Blood is much easier, it's fluid, it's all over the place. So you pick up single cells and keep knocking it off. Solid tumor, it's in one place and it's got a fortress. So this is where we are, and I'm sure it's a question of time we'll find the answer. And we are using AI amply to actually tackle with this, okay? And always the ethics and limitations you have to know. And our country is happening. I want to tell you what's been done, okay? So AI in radiology is a big thing now. Any radiologist here? Yeah. So, you know, but what happens when a reading of an MRI is wrong and the patient sues? Who will you put the blame on? The AI, the doctor, or the institute? It's an ethical question. He has sued you. You missed a lesion on the MRI and has gone through the AI under signature of a consultant. So these are real-time questions. Actually, they're in our country even now, and offshoot of telemedicine and things like that. So here are 2 documents. It's in the public domain. 3 downloads. ICMR, Ethical Guidelines, National Academy, where I am a council member for the last 5 or 6 years now, where I'm the president-elect. We have got 20 task force for the unmet needs of the country. Okay, this is task force number 7, where we actually have brought out with all the pundits in our country on AI. We have brought this out. And here, if you see the chapters, they're giving you a backdrop, they're giving you the problems, and they also told you what you should do. Now, what's not happened is the regulatory process. The regulatory process, you must know. These are the facts, the evidences you must know. And here you see, it's come a long way in 2017. Now we have the DPDP Bill of 23. This also is in the public domain. So you have got a regulator who's working on it, but the goalpost keeps moving every day dynamically. So you have to follow up. What was there yesterday may not be true tomorrow. So you must keep following this, okay? In India, Immuno Act, IIT Powai, Bombay, and TMH Mumbai or TMC Mumbai now together have produced the first commercially available Immuno Act, which we have used. It cost us 40 lakhs. It's come down to 30 lakhs now. The second one in the market is from Bombay Biocon, Shaw and Company, and with NH, Narayana Hridayalaya, they come out with Immunil. This is still even now 50 lakhs in the market. They both are there in the market. Okay, we've used our first one, and this was a lady with ALL. We done it a few months ago, and so personalized medicine, ladies and gentlemen, like I've told you through the journey, you can use it for prevention, diagnosis, and treatment, undoubtedly, and you will obviously combine all this to shoot the problem down, whether it's cancer or something else. And this is the way to go. Use your omics and use your AI intelligently, okay? And that is what is called targeted therapy. Okay. And the challenges remain. Cost has to come down. Privacy of data, the complexity and the IP rights, things like that are bound to happen. And the doctor's worry is, am I going to be replaced? Well, this was shown by Raji too. But the comfort of talking to a doctor or a doctor touching you and examining you will remain. That can never be changed, at least in the years to come. It may happen sometime when we are not there, but not in the immediate future. I don't see it happening. So I say, will AI replace a doctor? Answer is no. Why? But definitely I think doctors not using AI will be replaced by doctors using AI. That is bound to happen. Okay, so that is a little catch here. And there's no doubt, brain plus computer, which I say human brain plus machine brain, put together will be better than either. There's no doubt about that. Okay, so we should use it. And empathy, which the machine doesn't have, you have. So that part will always be your baby. And that's why we should practice it. Okay, so to summarize, it's there, it's real, and we must use it. And the data is available and it is affordable. In the sense, what used to cost us 60,000 for a genomics data for, like, let's say BRCA. So the cost has come down to now less than 10,000. Turnaround time, which used to take 1.5 months, is now 2 weeks. So things are moving for you to tap it. Okay. So our country has recognized this. So the president has awarded for cell therapy and gene therapy. First, Dr. Advani from TMC in 11. I got in 11 from when I was in AFMC, and then again in 17, and then Dr. Maman from CMC Vellore in 2019. So the government also recognizes what you do, which is good. Which is the way to go. So I always tell my students, my favorite slide, that you must learn from yesterday, but we must live for today. Okay? But that does not stop you from hoping for tomorrow, which is what we live on. And the important thing, ladies and gentlemen, is don't ever stop questioning. And you will get the answer, I can tell you that. Okay? So thank you very much. I didn't see many people sleeping, or I didn't see anybody sleeping. I couldn't have done this without people and teams. So I acknowledge all these people, and it's been a journey which is reasonably long, but I feel it's very short, and I've enjoyed it every bit. And I want you all to join this journey of personalized medicine, which is the reality. Thank you very much.
Thank you. You'll all agree with me that was very, very insightful and delivered in Velu's inimitable, masterly manner. So kudos to you, Velu.
Thank you, sir.
And can we have the luxury of permitting him a little bit of interaction, Praful?
Sure.
Yeah, okay. Any audience participation? Well, then I think, yeah.
Yeah. So, in the armed forces, we in RR hospital, we set up a lab also. So we did these 2 trials, and, the funding is an issue, because you need, like our funding was 11 crores, which was more than what the FMRC whole budget was. So that is one issue. So we have to collaborate. And today, the platforms of DBTI, CMR, CSIR are all willing to fund you. So we must collaborate, and you must have the passion, and you must have a team. And our team had not only hematologists, we had good bunch of pathologists who had the passion for it. So the armed forces must pursue regenerative medicine, and you have to take out some people. When I did my high-altitude study, I didn't look for geniuses or senior people. I looked for people with a passion who were dying to reach Ladakh and didn't want to come back. My problem was to get them back after we reached there. So passion is what you need. And with passion will come leadership. And with leadership will come a team. And the forces will always support you. We have people, progressive people like General Sandeep now in the chair. And I know the bunch of them, all of you are going to be there tomorrow. So it's up to you now. But we could do it. You will do it better than us. So I think you will have to sort of, get going and set it up and get the people who want to do it. You can't force it on anybody. I realized this is one area you can't force it on it. Yes, one more question from there.
Yeah, one more.
Yeah.
Yeah, the young lady.
Oh,
Sir, I wanted to ask you, sir, thank you firstly, sir, for the amazing talk. Sir, when you mentioned about AI being more accurate and how can we, when we are using AI, how can we ensure that we are using AI in a way that it is more accurate? Because many a times when we put in some input and we would get a particular answer, and maybe later on if we give it in a different way, we would get a different answer. And also, sir, how can we develop AI to suit our needs so that we can ensure that the AI that others use would
thank
be
you.
more
I've
accurate?
got your question. You know, this is a evolving field, what you asked, Major Ipshita. And that is, you know, firstly, are there any training courses to actually train you to do what you should do to answer your questions? So how should I use an AI? And is the AI a validated model? Okay, so a validated model is very important. Just generate in the backyard of your own workplace may give you the wrong answers. So there are many silos working which need to be validated with a common denominator. But don't have the common denominator, and who decides the common denominator? The government of India. The country's need. And the private players come on board as a PPP model, as a public-private partnership model. So you need to have validated AIs. You need to have, I showed you one slide, we don't have enough training. So NAMS has started a 3-month training with the IIIT Hyderabad, which lasts 3 months and costs you also a package, costs 40,000 or something around that. It's a 3-month course. It's a virtual course. The first course is ending now, and we are oversubscribed for the next course. We hope to run at least 3 in a year. So the government of India is going to bring out certain things where there'll be an audit tool. There'll be an exit audit. That anybody and everybody attending doesn't become an AI specialist. He has to prove his or her worth at the exit by an audit. So all those things are yet to be put in place. So it's very new in our country, but your answers will definitely be formalized in the next, I would say, couple of years. But they're very relevant questions. Yeah.
Well, thank you. And I think that was a very, very vibrant session. Thank you all, and maybe.
Thank you. Thank you. Oh. Hi, Raji.
Major General Giriraj Singh, Dean and Deputy Commandant, to please felicitate our chairperson.
With this, we have concluded this session. I request all delegates to join us for high tea at the bridge on the second floor of this building. We will reassemble after this session, after the tea, at 11:20. All those delegates who have not registered yet, I request you to please go to Dronacharya Hall and get yourself